Changes in sexuality. The sexual interest and activity of pregnant women and their partners are unpredictable and may increase, decline, or remain unchanged. The woman's physical comfort and sense of well-being are closely linked to her interest in sexual activity. The culture of the couple is also important. Intercourse during pregnancy is allowed and encouraged in some cultures, but strictly forbidden in others. During the first trimester, freedom from worry about becoming pregnant or the need for contraception may provide a sense of freedom and enhanced sexual interest in both partners. However, nausea, fatigue, and breast tenderness may interfere with erotic feelings. Fear of miscarriage may cause couples to avoid intercourse, particularly if the woman has previously lost a pregnancy or has had infertility therapy. Nurses can reassure the couple that no evidence shows intercourse to be related to early pregnancy loss when no complications are present. In the second trimester, women experience increased sensitivity of the labia and clitoris and increased vaginal lubrication from pelvic vasocongestion. Nausea is no longer a concern by this time for most women. Many have a general feeling of well-being and energy that may increase sexual responsiveness. Orgasm may occur more frequently and with greater intensity during pregnancy because of these changes. Although orgasm causes temporary uterine contractions, they are not harmful if the pregnancy has been normal. During the third trimester, the missionary position, male on top, may cause discomfort because of abdominal pressure. Heartburn, indigestion, and supine hypotensive syndrome also increase in this position. The pressure of the fetus low in the pelvis may add to the discomfort. Moreover, fatigue, ligament pain, urinary frequency, and shortness of breath may be problems. The nurse can suggest alternative positions such as female superior, side to side, or vaginal rear entry from intercourse. The side-lying position may be the most comfortable and require the least amount of energy during the third trimester. Hugging, cuddling, kissing, and mutual massage or masturbation are other ways to express affection without vaginal intercourse. As they become larger, some women believe their bodies are ugly and worry about their partner's reaction to their increased size. Sexual response varies widely among men. Some men report heightened feelings of sexual interest, but others perceive the woman's body in late pregnancy as unattractive and erotic feelings may decrease. In addition, fear of harming the fetus or causing discomfort to the woman may interfere with sexual activity. Despite the need for information, many women are reluctant to initiate a discussion about sexual activity. Unfortunately, most healthcare professionals do not introduce the topic. They may fear offending the woman or may be uncomfortable with their own sexuality and embarrassed to begin a discussion. They often lack time for any but the most pressing assessments. The result may be that an important aspect of care is ignored. A broad opening statement may help initiate discussion about sexual activity. For example, sometimes couples are concerned about having sex during pregnancy. Such statements introduce the subject in a way that lets the woman feel comfortable either pursuing it or ignoring it. The couple should be made aware of the normal changes in sexual desire that occur during pregnancy and the importance of communicating their feelings openly with each other to find solutions to problems. The nurse can reassure the couple that their feelings are normal. Intercourse is safe throughout pregnancy if there are no complications. Bleeding, an incompetent cervix, placenta previa, rupture of membranes, and history of preterm labor in the present pregnancy are contraindications for intercourse. In addition, blowing into the vagina should be avoided at any time because it can cause an air embolus. Third trimester. Vulnerability. The sense of well-being and contentment that dominates the second trimester gives way to increasing feelings of vulnerability that peak in the third trimester during the 7th month. The expectant mother may worry that the precious baby may be lost or harmed if not protected at all times. She often has fantasies or nightmares about having a deformed baby or harm coming to the infant and may become very cautious as a result. She may avoid crowds because she feels unable to protect the infant from infectious diseases or potential physical dangers. She needs reassurance that such dreams and fears are not unusual in pregnancy. Increasing dependence. The expectant mother often becomes increasingly dependent on her partner in the last weeks of pregnancy. She may insist that he be easy to reach at all times and may call his cell phone or place of work several times during the day. She may rely on her partner and others more at this time and seek their help in making decisions. This may be frustrating if it is a marked change for her. Women often have fears about the safety of the partner and that something will happen to him. Her need for love and attention from her partner is even more pronounced in late pregnancy. When she is assured of his concern and willingness to provide assistance, she feels more secure and able to cope. Although the woman may not be able to explain the increasing dependence, she expects her partner to understand the feeling and may become angry if he is not sympathetic. Irritability may increase because of her fatigue at this time as well. The nurse can encourage couples to discuss fears and feelings openly so that misunderstandings can be avoided. Some pregnant women have difficulty with tasks that require direct, sustained attention, particularly in the third trimester. Women may feel they have trouble concentrating or focusing on learning new material or skills at this time. Teaching should be clear and concise to help women learn most easily. Preparation for birth. Gradually, the feelings of vulnerability decrease as the woman comes to terms with her situation. The fetus continues to grow, and fetal movements are no longer gentle. The woman's relationship with the fetus changes as she acknowledges that although she and the fetus are interrelated, the baby is a pervasive presence and not a part of herself. Although she may not consciously acknowledge the increasing feelings of separateness, she longs to see the baby and becomes acquainted with her child. Most pregnant women are concerned about their ability to determine when they are in labor. Many couples are anxious about getting to the birth facility in time for the birth, and they may be worried about coping with labor. During the last few weeks, the woman becomes increasingly concerned about her due date and the experience of labor and delivery. They often say they are tired of being pregnant and want the pregnancy to be over. Women pregnant for the first time are more likely to fear childbirth than multiparas. Many women fear the pain of childbirth or that something will go wrong during labor. Multiparas, who had a previous negative pregnancy or birth experience, have increased concerns during the current pregnancy. Worry may also increase if friends or relatives have had difficult pregnancies. Women may seek help for their fears by talking to members of their support system or by seeking information from healthcare professionals, books, television, or the internet. However, information from websites or TV may not always be scientifically based, show practices that are evidence-based, or depict experiences that are most common. During the third trimester, an expectant mother prepares for the infant, if that is appropriate in her culture. Nesting behavior includes obtaining clothing and furniture and arranging a place for the infant to sleep. Negotiation of how the couple will share household tasks is among the plans made at this time. In addition, many couples complete childbirth education classes, see Chapter 7. Table 6.3 summarizes changes in maternal responses during pregnancy. Maternal role transition. Becoming a mother involves intense feelings of love, tenderness, and devotion that endure over a lifetime. How does a woman learn to be a mother? Role transition is changing from one pattern of behavior and self-image into another. The transition into the mother role begins during pregnancy and increases with gestational age. The woman must accept the pregnancy and the changes that will result. She develops a relationship with the unborn child, first as part of herself, and then as a separate individual. Near the end of pregnancy, she must prepare herself for the birth and for parenting the new baby. Transitions experienced throughout pregnancy. The woman undergoes transitions in relationships that continue throughout the pregnancy. She becomes more aware of herself and the changes occurring in her life. Her relationship with the father changes as they both prepare for parenthood. Her relationship with her own mother is often examined and may change as the expectant mother develops a view of herself as a mother and what the role entails. The woman needs mentors to help her understand that her feelings and experiences during pregnancy are normal. She also needs support from other new mothers. Steps in maternal role-taking. Rubin, 1984, in her classic work, observed specific steps that provide a framework for understanding the process of maternal role-taking: mimicry, role-play, fantasy, the search for a role fit, and grief work. Mimicry. Mimicry involves observing and copying the behaviors of other women who are pregnant or mothers to discover what the role is like. Mimicry often begins in the first trimester, when the woman may wear maternity clothes before they are needed to understand the feelings of women in more advanced pregnancy and see how others react to her. She may also mimic the waddling gait or posture of a woman who is close to delivery long before these changes occur for her. Role play. Role play consists of acting out some aspects of what mothers do. The pregnant woman searches for opportunities to hold or care for infants in the presence of another person. Role-playing gives her an opportunity to practice the expected role and receive validation from an observer that she has functioned well. She is particularly sensitive to the responses of her partner and her own mother. Fantasy. Fantasies, mental images formed to prepare for the birth of a child, allow the woman to consider a variety of possibilities and daydream or try on a variety of behaviors. Fantasies often revolve around how the infant will look and what characteristics he or she will have. The woman may daydream about taking her child to the park, or reading or singing songs to the child. She may also have vivid dreams at night. At times, fantasies are fearful. Fearful fantasies often provoke a pregnant woman to respond by seeking information or reassurance. For instance, she may ask her partner if he will love the baby even if he or she is not perfect, or she may strive to learn all she can about caring for a baby who is difficult to console. Fantasies may change during each trimester and may be different for primigravidas and multigravidas. Fantasies are most frequent during the third trimester. The nurse shows acceptance and understanding by listening to a woman's fantasies. In addition, listening helps the nurse identify concerns that may need further discussion. The search for a role fit. The search for a role fit occurs once the woman has established a set of role expectations for herself and internalized a view of a good mother's behavior. She then observes the behaviors of various mothers and compares them with her own expectations of herself. She imagines herself acting in the same way and either rejects or accepts the behaviors, depending on how well they fit her idea of what is right. This process implies that the woman has explored the role of mother long enough to have developed a sense of herself in the role and to be able to select behaviors that reaffirm her view of how she will fulfill the role. Grief work. Although grief work seems incongruous with maternal role-taking, women often experience a sense of sadness when they realize that they must give up certain aspects of their previous selves and can never go back. A primigravida will never again be a carefree woman who has not had a child. She must relinquish some of her old patterns of behavior to take on the new identity as a mother. Even simple things such as going shopping or to the movies will require planning to include the infant or find alternative care. The multipara will have one more child claiming her attention. Changes may be particularly difficult for the adolescent mother, who is not used to planning ahead and may have to give up or change school plans as well. Maternal tasks of pregnancy. To become mothers, pregnant women spend a great deal of time and energy learning new behaviors. As the woman works to establish a relationship with the infant, she must also reorder her relationship with her partner and family. The psychological work of pregnancy has been grouped into the following 4 maternal tasks of pregnancy. Rubin, 1984. 1. Seeking safe passage for herself and baby through pregnancy, labor, and childbirth. 2. Gaining acceptance of the baby and herself from her partner and family. 3. Learning to give of herself. 4. Developing attachment and interconnection with the unknown child. Seeking safe passage. Seeking safe passage for herself and her baby is a woman's priority task. If she cannot be assured of that safety, she cannot move on to the other tasks. Behaviors that ensure safe passage include seeking the care of a physician or nurse midwife and following recommendations about diet, vitamins, rest, and subsequent visits for care. In addition to following the advice of healthcare professionals, the pregnant woman must also adhere to cultural practices that ensure safety for herself and the infant. Securing acceptance. Securing acceptance is a process that continues throughout pregnancy. It involves reworking relationships so that the important persons in the family accept the woman in the role of mother and welcome the baby into the family constellation. In her first pregnancy, the woman and the father of the baby must give up an exclusive relationship and make a place in their lives for a child. When her partner expresses pride and joy in each pregnancy, the woman feels valued and comforted. This feeling is so important that many women retain a memory of their partner's reaction to the announcement of pregnancy for many years. Support and acceptance from her own mother are also important. The pregnant woman gains energy and contentment when her mother freely offers acceptance and support. Many expectant mothers gain a sense of increased closeness with their mothers during pregnancy. Figure 6.11. Problems may occur if the family strongly desires a child with particular characteristics, and the woman thinks the family may reject an infant who does not meet the criteria. Learning to give of herself. Giving is one of the most idealized components of motherhood, but one that is essential. Learning to give to the coming infant begins in pregnancy, when the woman allows her body to give space and nurturing to the fetus. She tests her ability to derive pleasure from giving by providing food, care, and acts of thoughtfulness for her family. The acceptance and enjoyment of the gift enhance her pleasure and strengthen the role. She also may give small gifts to friends, especially those who are pregnant. Pregnant women also learn to give by receiving. Gifts received at baby showers are more than needed items. They also confirm continued interest and commitment from friends and family and enhance the woman's ability to give. Intangible gifts from others, such as companionship, attention, and support, help increase her energy and affirm the importance of giving. Committing herself to the unknown child. The process of attachment, development of strong affectional ties, begins in early pregnancy when the woman accepts or binds in to the idea that she is pregnant, even though the baby is not yet real to her. During the second trimester, the baby becomes real and feelings of love and attachment surge. This is especially true when quickening occurs or after an ultrasound shows recognizable parts of the body. Mothers report feedback from their unborn infants during the third trimester and describe unique characteristics of the fetus about sleep-wake cycles, temperament, and communication. Love of the infant becomes possessive and leads to feelings of vulnerability. The woman integrates the role of mother into her image of herself. She becomes comfortable with the idea of herself as mother and finds pleasure in contemplating the new role. Some women delay attachment to the fetus until they feel sure the pregnancy is normal and will continue. This is especially true for women who have lost a pregnancy previously. They may begin to have feelings of attachment after they have passed a critical time that correlates to the time they lost a previous pregnancy. Paternal adaptation. Expectant fathers do not experience the biologic processes of pregnancy, but they also must make major psychological changes to adapt to a new role. These changes may be more difficult because the male partner is often neglected by the healthcare team and his peer group, because attention is focused on the woman. His concerns and anxieties may remain unknown because of the lack of focus on him. Variations in paternal adaptation. Wide variations exist in paternal responses to pregnancy. Some men are emotionally invested and comfortable as full partners, exploring every aspect of pregnancy, childbirth, and parenting. Others are more task-oriented and view themselves as managers. They may direct a woman's diet and rest periods and act as coaches during childbirth, but remain detached from the emotional aspects of the experience. Some men are more comfortable as observers and prefer not to participate. In some cultures, men are conditioned to see pregnancy and childbirth as women's work, and may not be able to express their true feelings about pregnancy and fatherhood. Readiness for fatherhood is more likely if a stable relationship between the partners, financial security, and a desire for parenthood are present. Additional factors include the man's relationship with his own father, his previous experience with children, and his confidence in his ability to care for the infant. Fathers have many concerns during a pregnancy. Coping with the expectant mother's emotional lability can be confusing and difficult. Common concerns include anxiety about the health of the mother and baby, financial concerns, and apprehension about his role during the birth and about the changes that will result when the baby arrives. Financial concerns may be especially acute in a two-income family if the mother develops complications that prevent her from working as long as expected. Men may seek a second job or work overtime to prepare for the increased financial needs. Developmental processes. The response of the expectant father are dynamic, progressing through phases that are subject to individual variation. Jordan, 1990, describes the following 3 developmental processes that an expectant father must address. Grappling with the reality of pregnancy and the new child. Struggling for recognition as a parent from his family and social network. Making an effort to be seen as relevant to childbearing. The reality of pregnancy and the child. The pregnancy and the child must become real before a man can assume the identity of father. The process requires time and may be incomplete until the birth. Initially, the pregnancy is a diagnosis only, and changes in the expectant woman's behavior, such as nausea and fatigue, are perceived as symptoms of illness that have little to do with having a baby. A man's initial reaction to the announcement of pregnancy may be pride and joy, but he often experiences the same ambivalence as his partner. Various experiences act as catalysts or reality boosters that make the child more real. Figure 6.12. The most frequently mentioned experiences are seeing the fetus on an ultrasound, hearing the baby's heartbeat, and feeling the infant move. Preparing room for the baby and accumulating supplies also reinforce the reality of the coming child. These tasks often represent the first time the expectant father has the opportunity to do something directly for the baby. The birth itself is the most powerful reality booster, and the infant becomes real to the father when he has an opportunity to see and hold the baby. The struggle for recognition as a parent. Men are often perceived by others as helpmates, but not parents in their own right. Some men may be upset that their feelings are not validated and that they may not be recognized as parents as well as helpers. Many men accept that the focus should be on their partners, but others are frustrated by the lack of understanding of their own experiences. Support groups or classes for expectant fathers are sometimes available. These groups allow them to talk with other men about changes resulting from the pregnancy and how these changes have affected them. Knowing his experiences and feelings are shared by other men in the same situation is very helpful. Expectant mothers play an important role in helping their partners gain recognition as parents. Women who openly share their physical sensations and emotions help expectant fathers feel they are part of the process. These women often say "we" are pregnant and include their partners in all discussions and decisions. Nurses should learn to view the mother, the father, and the infant as one patient and not focus exclusively on the mother and the fetus. The nurse should encourage men to ask questions about their partner's pregnancies. These men are entitled to as much advice and reassurance as expectant women. Men who have sufficient information about pregnancy, birth, and newborn care are less likely to be as psychologically stressed as men who do not feel they have enough information. Internet resources such as the American College of Obstetricians and Gynecologists also provide valuable information for partners at www.acog.org. The nurse can guide the couple in discussion of the role the father will play during and after the birth. How actively will he participate during labor? Will he be involved in infant care from the start or wait until the baby is older? The expectant parents may be surprised to learn each other's views and will need to negotiate, taking the beliefs of each partner into consideration to determine the roles each will play. Creating the role of the involved father. Men use various means to create a parenting role that is comfortable for them. They may seek closer ties with their fathers to reminisce about their own childhoods. They may fantasize about their relationships with their children as they progress through the stages of childhood. Expectant fathers also observe men who are already fathers and try on fathering behaviors to determine whether they are comfortable and fit their own concepts of the father role. Some men change their self-images and even their appearances to fit their new images. In addition, many men assertively seek information about infant care and growth and development so they will be prepared. Parenting information. Expectant fathers need information about infant care and parenting. Although adequate information may be given to them, fathers may not be ready to learn at the time it is provided. As a result, they may have unrealistic expectations and be unprepared to care for the newborn. Nurses should review information about infant care and growth and development after the infant is born when the knowledge is immediately relevant. Couvade. The term couvade refers to pregnancy-related symptoms and behavior in expectant fathers. In primitive cultures, couvade took the form of rituals involving special dress, confinement, limitations of physical work, avoidance of certain food, sexual restraint, and in some instances, performance of mock labor. In modern practice, expectant fathers sometimes experience physical symptoms similar to those of pregnant women, such as loss of appetite, nausea, headache, fatigue, and weight gain. Symptoms are more likely to occur in early pregnancy and lessen as the pregnancy progresses. They may be caused by stress, anxiety, or empathy for the pregnant partner. They are usually harmless but may persist and result in nervousness, insomnia, restlessness, and irritability. Although the symptoms are almost always unobserved by the healthcare team, anticipatory guidance is beneficial for both partners. Adaptation of grandparents. The initial reaction of grandparents depends on factors such as their ages, the number and spacing of other grandchildren, and their perceptions as the role of grandparents. Age. Age is a major determining factor in the emotional responses of prospective grandparents. Older grandparents have often already dealt with their feelings about aging and react with joy when they find they are to become grandparents. They look forward to being able to love grandchildren, who signify the continuity of life and family. Younger grandparents may not be happy with the stereotype of grandparents as old persons. They may experience conflict when they must resolve their self-image with the stereotype. They often have career responsibilities and may not be accessible because of the continuing demand of their own lives. Number and spacing of other grandchildren. The number and spacing of other grandchildren also determine grandparents' reactions. A first grandchild may be an exciting event that creates great joy. If the grandparents have other grandchildren, another may be welcomed. but with less excitement. The subdued reaction may be disappointing to the couple, who may desire the same reaction as that expressed for the first grandchild. Perceptions of the role of grandparents. Grandparents' beliefs about their importance to grandchildren vary widely. Many grandparents see their relationships with grandchildren as second in importance only to the parent-child relationship. They want to be involved in the pregnancy, and grandmothers often engage in rituals such as shopping and gift-giving showers that confirm their role as important participants. Many grandparents are intimately involved in childcare and offer unconditional love to the child. They offer to care for older children while the mother gives birth, and they assist during the first weeks after childbirth. In the past, grandparents were often asked for advice about childbearing and child-rearing. Healthcare personnel have now become the experts, and many grandparents have difficulty adjusting to this change. Some grandparents may withdraw, sensing that their participation is no longer valued. Other grandparents worry about their lack of familiarity with modern ways of childbearing and parenting. Special classes are often available to teach them about current childbearing practices. On the other hand, some contemporary grandparents plan little participation in pregnancy or childcare. They may say, "I've raised my children, and I don't plan to do it again." This attitude often results in conflicts with the parents, who may feel hurt and wish for the grandparents' help during the third trimester and after the birth. Nurses can assist families to verbalize their feelings about the grandparents' responses to the pregnancy by statements such as, "It may seem that the grandparents aren't interested in the baby, but perhaps they are uneasy about what their role should be." Parents and grandparents may need to negotiate how the grandparents can be involved without feeling that they must assume more care of the child than they desire. For instance, the couple may need suggestions to help their grandparents participate in family gatherings that do not involve babysitting or childcare. Letting grandparents know that the parents want them to share in the joy the child brings without other expectations may ease the situation. Adaptation of siblings. Sibling adaptation to the birth of an infant depends largely on age and developmental level. Toddlers. Children 2 years old or younger are unaware of the maternal changes occurring during pregnancy and are unable to understand that a new brother or sister is going to be born. Because toddlers have little perception of time, many parents delay telling them that a baby is expected until shortly before the birth. Although preparing very young children for the birth of a baby is difficult, the nurse can make suggestions that may prove helpful. Any changes in sleeping arrangements should be made several weeks before the birth so the child does not feel displaced by the new baby. Many members should be prepared that toddlers may show feelings of jealousy or resentment. Toddlers need frequent reassurance that they are loved. Older children. Children from 3 to 12 years are more aware of changes in the mother's body and may realize a baby is to be born. They may enjoy observing the mother's abdomen, feeling the fetus move, and listening to the heartbeat. They may have questions about how the fetus will develop, how it was created, and how it will get out of the abdomen. Although they look forward to the baby's arrival, preschool children may expect the infant to be a full-fledged playmate and may be shocked and disappointed when the infant is small and helpless. They also need preparation for the fact that the mother will go away for several days when the baby is born. School-aged children are often told about the pregnancy during the second trimester and benefit from being included in preparations for the new baby. They are interested in following the development of the fetus, preparing space for the infant to sleep, and help accumulate supplies the infant will need. They should be encouraged to feel the fetus move and may come close to the mother's abdomen and talk to the fetus. School-aged children may wonder how the birth will affect their role in the family. Parents should address these concerns and reassure the children about their continued importance. Providing time alone with the parents may help them gain a sense of security. Figure 6.13. Reading books about other children's experiences after the birth of a sibling may be helpful. Children as young as 3 years can benefit from sibling classes. The classes provide an opportunity for them to discuss what newborns are like and what changes a new baby will bring to the family. They are encouraged to bring a doll to these classes to simulate caring for the infant. In some settings, siblings are permitted to be with the mother during childbirth. They should attend a class that prepares them for the event. During the birth, a familiar person who has no other role but to support and care for younger siblings should be available to explain what is taking place and to comfort or remove them if events become overwhelming. Adolescence. The response of adolescents also depends on their developmental level. Some are embarrassed because the pregnancy confirms the continued sexuality of their parents. Many adolescents are immersed in their own developmental tasks involving loosening ties to their parents and coming to terms with their own sexuality. They may be indifferent to the pregnancy unless it directly affects them or their activities. Other adolescents become very involved and want to help with preparations for the baby. Factors influencing psychosocial adaptations. Age. Pregnancy presents a challenge for teenagers who must cope with the conflicting developmental tasks of pregnancy and adolescence at the same time. The major developmental task of adolescence is to form and become comfortable with a sense of self. On the other hand, one of the major tasks of pregnancy involves learning to give of self, a process that includes sacrificing personal desires for the benefit of the fetus. Nurses who work with pregnant teenagers should help them to adjust to their changing bodies and the increasing presence of the developing fetus. Adolescents also need prompting to follow a lifestyle that promotes the best outcomes for them and their infants. The pregnant woman over 35 years of age also may have some concerns. Pregnancy may mean a major change in her life. She may have medical conditions that have an impact on the pregnancy as well. Concerns relating to the pregnant adolescent and the older woman are discussed further in Chapter 11. Multiparity. The assumption that a multipara needs less help than a first-time mother is inaccurate. Pregnancy tasks are often more complex for the multipara than for the prima gravida. The multipara does not have as much time to take special care of herself as she did during the first pregnancy. She is more likely to experience fatigue and may have serious concerns about her other children accepting the infant. She may worry about finding time and energy for additional responsibilities. When seeking acceptance of the new baby, the multipara may find the family less excited than they were for the first child. The couple's celebration is also more subdued. The woman spends a great deal of time developing a new relationship with the first child, who may become demanding. This behavior may foster feelings of guilt as the mother tries to expand her love to include the second child. Developing attachment for the coming baby is hampered by feelings of loss between herself and the first child. She senses that the child is growing up and away from her, and she may grieve for the loss of her special relationship. Nurses cannot assume that the process is old hat and that information about labor, breastfeeding, and infant care is not needed. The parents also may need special assistance in integrating an additional infant into the family structure. Social support. Social support has been found to be a significant predictor of health-related quality of life during the perinatal period. Alden, 2014. Social support comes from the woman's partner, family, friends, and coworkers. Generally, support from the woman's partner and her mother is particularly important. Depression may occur in women who have little support during pregnancy, and they are more likely to begin prenatal care late. The nurse should assess for signs of depression in all women and refer them for help when necessary. See Chapter 11 for a discussion of peripartum depression. When social support is inadequate, the nurse can help the woman explore potential sources, such as support groups, childbearing education classes, church, work, or school. Some community programs employ nurses or paraprofessionals to visit expectant mothers to provide teaching and social support. Absence of a partner. Pregnant single women may have special concerns. Although some unmarried women have the financial and emotional support of a partner, others do not. They may experience more stress about telling their family and friends about their pregnancy. They may have to enlist more social support to substitute for that of a partner. Legal issues such as whom to list as the father on birth records and what arrangements must be made to allow paternal contact with the infant may be added concerns. Many single women without partners live below the poverty level. They are more likely to delay prenatal care until the second or third trimester and are at increased risk for pregnancy complications and delivery of a low birth weight infant. Nurses should recognize a single mother's needs for accessible and affordable prenatal care. In addition, nurses should be prepared to offer specialized supportive care for single mothers. Necessary social services may include Medicaid, the Special Supplemental Nutrition Program for Women, Infants, and Children, WIC, for food vouchers, and transportation to prenatal appointments. Some women are single by choice. They may have been inseminated to achieve pregnancy or choose not to continue the relationship with the father. If the pregnancy was planned, these women may have fewer financial concerns. Abnormal situations. Other factors that influence psychosocial adaptation during pregnancy include abnormal situations such as intimate partner violence, substance abuse, see chapters 2 and 11, or the death of a partner. The nurse should assess all women for both of these risk factors during pregnancy so that appropriate referrals for help can be given.